Hello everyone, I am Dr. Vibhuti Shah. We'll talk on complication of spinal anesthesia. Complication of spinal anesthesia results due to either exaggerated physiological response, drug toxicity, or needle placement. Complication can be classified as immediate complication and late complication. Immediate complication includes hypotension, bradycardia, and cardiac arrest, high and total spinal block leading to the respiratory arrest, whereas urinary retention, epidural hematoma, and bleeding can be classified as early complication. Late complication includes posterior puncture headache, backache, nausea, focal neurological deficit, bacterial meningitis, cyst cranial palsy. Anterior spinal artery syndrome is a complication which occurs immediately but manifests as a late complication. Exaggerated physiological response include high needle blockade, cardiac arrest, and urinary retention. This category is an extension of normal physiological manifestation. The main point is a vigilance and early treatment. Treat hypotension early and do not let it progress to cardiac arrest. Knowledge, preparation, and anticipation can help to reduce the adverse or the exaggerated physiological response. Treatment of the high needle blockade is changing with the position, supplementation of oxygen, fast loading of IV fluid, and treatment of hypotension with the ephedrine or phenylephrine and bradycardia with the atropine. Whereas the treatment of the cardiac arrest, if it occurs, is as per the ABCs. Maintain airway, breathing and circulation as enlisted previously. If required, intubate the patient, ventilate and support with the inotropes. Urinary retention is due to the blockage of S2 to S4 dermatomes, which leads to the decrease in the bladder tone and inhibition of the normal voiding reflex. Neuroaxial opioids may contribute to urinary retention, and this is more common in elderly patients, those who are suffering from the benign prostatic enlargement. Complications associated with the needle placement are inadequate anesthesia or analgesia, inadvertent intravascular injection, subdural injection, backache, posterior puncture headache, neurological injury, spinal hematoma, meningitis and arachidonitis, and coda equina syndrome. Inadequate analgesia or anesthesia, for example, Apache block, results when needle is not entirely in the subarachnoid space. Risk of inadvertent intravenous injection is extremely low with spinal anesthesia, and vigilance is the only solution. Anterior spinal artery results due to damage to the corticospinal and spinothalamic tracts. It results in loss of motor function and pain below the level of injury. It requires early diagnosis with CT, MRI, and immediate surgical decompression. Still, prognosis is poor, so negative aspiration for the blood before the drug injection is must. Anterior spinal artery results due to damage to the corticospinal and spinothalamic tracts. It results in loss of motor function and pain below the level of injury. It requires early diagnosis with CT, MRI, and immediate surgical decompression. Still, prognosis is poor, so negative aspiration for the blood before the drug injection is must. Backache rarely occurs due to spinal anesthesia. If at all it occurs, it is late in onset, short-lived, and can be managed with analgesic. Severe throbbing early backache should arouse the suspicion of epidural hematoma or abscess. Posterior puncture headache results due to leakage of CSF from dural puncture, which cause traction on dura and tentorium. It can occur with spinal or wet epidural tap. Headache is throbbing, bilateral, frontal, retroorbital, or occipital, with or without radiation to neck, more in upright position and relieved in supine position. Its onset is generally within 12 to 72 hours of spinal anesthesia. Conservative management of posterior puncture headache includes caffeine intravenously or oral and NSAIDs. Definitive treatment of posterior puncture headache is epidural blood patch, which is offered after 12 to 24 hours of failed conservative management. After ruling out bleeding diathesis and infection, 15 to 20 ml of patient's own blood is injected at or below the level of dural puncture. Neurological injury can be transient or permanent. Prevention of neurological injury is done by avoiding the trauma to the nerve roots or spinal cord. Identification of the appropriate landmark is essential and always document the pre-existing neurological deficit. Incidence of spinal hematoma is 1 in 2 lakhs. It results due to the bleeding diathesis or multiple traumatic attempts. It manifests as a sharp back and leg pain. It results in progressive numbness, motor weakness, and sphincter dysfunction. Meningitis is a very rare complication. Presentation is very similar to the post-dural puncture headache, but there is no postural component to the headache, and headache is usually associated with the fever and alteration in the level of consciousness. Arachnoiditis is a rare complication. It is a complication of past when disposable equipments were not available. Cauda equina syndrome is due to the peripheral nerve injury to lumbar, sacral, and coccygeal nerve roots. Symptoms are variable motor and sensory loss in lower extremity, sciatica, bone and bladder dysfunction, sudden anesthesia. But the prognosis of disease is good. This is a brief summary of the complication of the spinal anesthesia. Thank you very much.